Okay, and you all saw that I did put it there, right? That I posted the PowerPoint?
Yes.
Yeah. Can I stop video? You can still see my screen?
Yes.
Okay, good. Awesome. Then I'm going to do that way. All right. So basically, this lecture is going to just really try to focus on what's happening with the baby in a normal newborn delivery. Okay. It's easy for me to kind of get off into the not so normal situations for a baby, but try to stop me if I'm getting off into, don't let me do that, okay? Because we want to focus on normal versus a couple of variations of normal on when you're doing the physical exam. What is the difference between the AGA, LGA, SGA, preterm and post-mature neonates, and what would you see in those exams to go, oh, he's a LGA baby. Oh, he's an infant of a diabetic mom who's a AGA or LGA baby. So again, go to these objectives, okay? I will write objectives going to this. If you, let's see, transition from fetal to neo, thermal regulation. So maybe I can't put a, okay. And then the next one is, this has to do with, just one second, you guys, I'm going to actually turn the slide off just a sec. You can't see me anyways. It's going to give me a seizure. It's going on and off. All right. So is this too dark for you? The screen?
No, it's fine.
Okay. All right. It says about prevention of infant abduction. Right now, for those of you that are in the OB and maternal infant unit, what do you know they are doing to help prevent infant abductions?
The wristbands that match both mother and baby and constant verification of those.
Good. And what else?
Locked doors.
Yeah.
There's like a tracking device that gets put on the baby.
Exactly. That tracking, that little umbilical clamp that they put on the baby at delivery, if it goes near any kind of exit, it locks the doors and it'll alarm. And both hospitals have those. All hospitals, I would say, should have them. So to start with, we talked a little bit early on about what happens with the lungs and how the lungs are forming in the embryonic. And then just as the infant grows older, what the lungs are actually looking like. And you can see here from 27 to 36 weeks and on, the alveoli are actually sacs, their formation, and that there is some surfactant that is detectable in the amniotic fluid. So that means that, the closer we get to 36 weeks, the more we feel like this infant should do all right as far as respiratory, okay? And if you look over here where it talks about surfactant lining the alveoli in reducing the surface tension. So basically what the surfactant does is it fills this inside of this balloon that would be like a balloon, and it acts as if you've put liquid detergent kind of thing in there, but it doesn't have the, what it's doing is it allows the lung, once it pops open and is open, the surfactant that lines it keeps that alveoli open. That's what you want. And we all know the fetal lung, the baby's been in the amniotic fluid, so that has to get out, it moves out into the interstitial spaces. Little bit before, as the infant is getting older in pushing into 36 and above weeks, during and after birth, what birthing process do you think may put the infant at a little bit increased risk for not moving the fluid out of the lungs?
Cesarean.
Cesarean, right. So those babies, you take, as the nurse, you're taking that in going, okay, this was a cesarean section, maybe a little on the early side, you know, a 36, 37 weeker. So those babies, you start almost like having this little checklist of, okay, this infant is at a little higher risk for maybe having some problems. So as far as initiation of respirations, there's basically 4 factors that are working here. One is the chemoreceptors in the carotid arteries and the aorta. They respond to the changes in the blood chemistry that brought about by hypoxia that occurs within normal birth. So the baby's delivering, these chemical receptors, the cord's been cut, chemical receptors are reacting to that process, okay? Mechanical factors, we already kind of said that. Thinking about a vaginal birth, the fetal chest is getting compressed, pushing out, and it actually says 1/3 of the fetal lung fluid is forced out of the lungs in the upper air passages during this time. Thermal factors, temperature is crucial, and we'll go into that more. I think I've said this before, but a cold baby, you could have a baby die of being cold, okay? Just the way their little systems work, depending on how big the baby, how much brown fat they have. So initially the temperature change from being in that nice warm environment, the baby comes out and is cold, and it initiates the respirations, but you then want to make sure you're taking the baby to the warmer and doing this tactile stimuli that to stimulate the drying the baby, and all of that helps get the respirations going. So like if I was at a cesarean section, I go in, the baby delivers, bring the baby out to the warmer, place them down. I'm already thinking, okay, we might have a little, all the lung fluid hasn't really come out. So you're stimulating the baby, getting them to cry, pushing that fluid out, and just do a little bulb suction. Not too much, because you don't want them to have a vagal response. Then, yeah.
I was just gonna say, what else would you do? Would you like rub their backside, upper backside?
Yeah, you'll see people do all sorts of different things. Mainly, I like the back better. It's you don't take an infant and turn them upside down and slap them on their feet or whatever. That's not good. The rubbing them on their back, really drying them. Just that dry, because you're doing 2 things. You're doing the skin stimulation, but you're also drying them and preventing them from using that more oxygen because they're cold. Okay.
Yeah. My C-section that I saw, they brought the infant out to the warmer. They turned her on the side, and they were rubbing her, drying her, like you were saying. Then they kept suctioning her, like frequently, like a lot.
Yes.
Until she started, she kept crying, and she would, her cry would get louder and louder. And,
yeah.
Yeah.
And she probably got pinker and pinker, and so
yeah. She did. exactly.
Excellent. And was she a term infant that was just a repeat C-section?
Yeah, she was.
Okay, good. Good. So, and now we go into thinking about what is happening in the cardiovascular part of the infant. So transitioning from the fetal to the neonatal circulation, I think you all had a simulation, didn't you, that you addressed part of this? Did you talk a little bit about it? No, you don't.
Yeah,
Well,
I think we did.
Yeah. Okay.
Yeah.
So basically what's happening is once so during the fetal life, there's 3 shunts: the ductus venosus, the foramen ovale, and the ductus arteriosus.
Oh yeah, we did go over this. We did go over
Okay.
this.
Okay, good. When the baby is delivered, the baby, the difference in pressures, baby comes out, starts to cry. The high pressure within the collapsed fluid for the lungs permits let me just go back to here. So the increase in blood oxygen level, because in utero, the PaO2 is low. The baby doesn't need, by the time the red blood cells get over and transport oxygen through the placenta to the infant, that PaO2 is lower than what mom would have. So increases in blood oxygen level when the baby comes out, the shifts in pressure in the heart and lungs. So now the lungs are being, the fluids being pushed out, the closing of the umbilical vessels cause the blood then to start, because now the blood has to go to the lungs to actually get oxygenated. The ductus arteriosus, the foramen ovale, and the ductus venosus start to close, okay? This is basically what they call it. If it stays open, it's called the PDA, patent ductus arteriosus. Or you could have a patent foramen ovale or a patent ductus venosus. Mainly, you'll hear people talk about this, not as high risk. It's kind of one of those things that it can take a few days, maybe even a few weeks sometimes to close down. This is a little more problematic, but the foramen ovale, but still it can close on its own. Sometimes you have to help these close, but they can. So I found this particular slide. I thought it was a little bit better. I really wanted to show you this one video from Stable course, but I couldn't get a hold of it. So this is what the fetal circulation looks like. So you can see the blood is coming in through the umbilicus, and you can see how it's turning. It's still oxygenated here. It's slightly oxygenated here. This particular area right here is what they call the ductus venosus. Okay, so that's what we talked about. This is part of the closing. You can see here, this is part of the liver circulation. And then going on up, the blood is coming from here. It actually crosses the foramen ovale, goes into the right atrium, and this is fetal circulation. Okay, and it's going to the lungs. It ends up in the lungs, but it's not, it's partially oxygenated, okay? You can see how it's pulling it back down. And then it comes back to the placenta to, exchange oxygenate and CO2 and all of that. So here is a picture of the circulation at birth. Basically, what I want you guys to understand is there is this transition. The baby has to go from this fetal circulation over to basically it's an adult type circulation. And all of these things have to happen in order for the blood to get to the lungs to get oxygenated and the rest of the body can get oxygenated. Okay. Let's see. Oops. I included this. It's a little long, so I'm not going to take the time to do it because I don't want to get off into a whole other area, because cardiac issues in the infant could take you off in different directions. And we're talking about normal newborn adaptation. So this is in here. It's really good. I would say you probably could skip the first 3 minutes of this and still get what you need. So now thermal regulation. The newborn, there's different characteristics about a newborn that puts it at higher risk for getting cold, for the inability to, what would you say? The inability to keep their temperature up. So those characteristics are the skin has very little subcutaneous tissue to it on some babies. Some babies have quite a bit. Blood vessels then are close to the surface. And what does that mean? That means that the blood is coming up along where it can get cold if the baby is cold. And the baby has a large skin surface. So the head is a little big. And that actually is a big portion of its skin surface, right? If the little baby's head is uncovered, how much heat would go out of that? There are 4 methods that babies get cold. And those are the evaporation, conduction, convection, and radiation. So this is what we mean. And when you think about, as you all who have watched deliveries now, as you pay attention to how they cared for the infant, you will realize why they did certain things. So first of all, evaporation. Evaporation can occur during the birth or bathing from the baby being wet and wet linens being around it, or a little wet t-shirt. So when you walk into a room and you see a baby maybe with a little wet t-shirt and laying in a crib like this, your hair should stand up a little bit. And you should go over, clean the baby up, wrap them, put a hat on. Okay. So that's evaporation. Conduction occurs when the infant comes in contact with cold objects. So at delivery, we warm the babies that giraffe. No, it's the kangaroo. We warm it so that the surface is not cold when we set the baby down, because it gets cold by conduction. Now, this also, think about those babies that you're giving a bath to, and you don't have maybe a heat source keeping the baby warm, or, you are, weighing the baby. Do it quickly. Don't leave the baby uncovered, because they'll lose heat from that. Convection is about putting a baby uncovered with, you can see an air conditioner, loose blanket, the door is open, maybe the side rails are down. So if you think about if you had a sick baby and everybody was working on this baby and nobody paid attention to, wow, the heater's not really on, we don't have the servo probe to the baby would get cold really quickly. And then you're working harder to get oxygenation going on this baby. And then there's heat loss by radiation. And they show a window where it's icy outside and the baby's there with no blanket on. And so the window is cold and it's putting cold onto the baby. Now, what other thing could be coming from the window?
Moisture.
Moisture, yep.
Sun, you can overheat the baby.
Yes, yeah. I mean, we're talking about heat loss, but you also got to be careful not to have the baby get too hot, because what are they gonna do? They're gonna breathe faster, they're gonna get tachypnic, and they're gonna get into problems that way too. Little less common, but still something you have to pay attention to. So when we talk about thermogenesis, basically, how does a baby produce heat? How does he keep his temperature up? Different things. So a healthy baby is going to be restless, moving around the crib, crying. They flex their muscles. They're increasing metabolism, so that warms them up. All of this is causing their vessels to vasoconstrict slightly. And they have this interesting thing they do. It's called non-shivering thermogenesis, which is related to brown fat. So all of these factors increase oxygen and glucose consumption. So you can see why, if you already have a baby that's having some issues, that it could result in respiratory distress, hypoglycemia, and jaundice. So non-shivering thermogenesis, basically when the baby is cold, whether it's from the window or from the open door and any of those things, the baby tries to keep themselves warm. So as vasoconstriction occurs to decrease the heat loss, acrocyanosis in the hands and feet will happen. The body metabolism rises, and basically they go through this process of breaking down the brown fat, metabolizing this brown fat. Now, what babies do you think then would be at higher risk for not being able to have this go on?
Preterm.
Say that again.
Preterm.
Preterm. What else? You're right. In preterm, it's because they have this like translucent skin. They have very little, if any, sub-Q fat. You can see through, usually through to the vessels. They just don't have any of those, the fat pads. What other baby do you think could get into trouble? What about a sick baby? What does a sick baby, what are they doing that you would think they're not able to keep themselves warm or do this thermogenesis?
All their energy is going to like fighting whatever is making them sick, or like helping keep their heart pumping or something, so they can't expend extra energy to keep themselves warm.
Exactly. And they even they're usually, you can walk into a room if a baby is one of those that are borderline and you're supposed to be keeping an eye on them. You can walk into the room, and if the baby is just laying there, I'm not talking those that are all wrapped up and they have their hands to their face and they have some flexion in their muscles. If they're just laying there flat, legs straight, arms straight, that's a baby that's going to get cold, right? Because now all of that surface area is exposed to the cold. They're not moving their muscles, generating, increasing their metabolism. So they get into trouble quickly. So again, the hazards of cold stress are they need more oxygen, because if they don't have the oxygen to break down this brown fat into energy, they get into this anaerobic type process, and it just sends them down a spiral, because then they need more oxygen in order to keep their temperature up, and it just is a spiral effect. So decreased surfactant production, respiratory distress, they can get into hypoglycemia, metabolic acidosis, and jaundice. So again, I think for an exam kind of thing, because I only have 5 questions, but I would say understanding the cold stress, what it does to the baby, is something you really need to understand, even just to take care of a normal newborn. You need to understand that if they get cold, all of these things start happening. Okay. And quite honestly, oh, well, right here, it shows that it returns to fetal circulation, and then the baby, the shunts that they should be closed now are opening back up. You get decreased oxygenation going around the whole body, and the infant can die from this. As far as the adaptation of the blood, and this is interesting as you guys are looking at your different, where's my little thing? As you're looking at infants' lab work, I know we don't get to see it much. I think you're going to see it more when you go to the NICU. Well, you will. Or if they said they really want to follow this baby for mom had a positive GBS, we're going to do a blood, a CBC, maybe a blood culture on the baby at so many hours of age. If they haven't had the antibiotics and everything, mom hasn't had the antibiotics prior to delivery. So erythrocytes, hemoglobin, and hematocrit, they're higher in the newborn than for adults because they, like I said, they had a lower PaO2 in utero. So all those red blood cells, they're smaller. They will break down, and that's why you get into the high bilirubin. But they are still there. So, and until that total transition of those red blood cells transition into adult red blood cells, that you're going to see the infant's hemoglobin and hematocrit will be higher. And then the white blood count can be higher. And they found that clotting factors for the newborn are low, probably having to do with the immature liver, right? So that is one of the reasons why we give vitamin K, right? It's one of those two medication, or 3. What are the 3 medications we're getting now?
Hep B, erythromycin, and the vitamin K.
Perfect. Yep. So then the GI system. It's really interesting. In the book, they brought this up too, but when you really think about it, it's kind of amazing. The newborn stomach capacity is 6 mLs per kilo. So that means if you have a 3-kilo baby, the capacity of its stomach at birth is 18 mLs. That's about a half an ounce, right? A little over a half an ounce. So you can see why this takes you into that whole issue, thinking about parents giving bottles like, oh, give the baby an ounce. Well, you give the baby an ounce in the first few hours, that baby will be throwing up for probably 12 hours. So you really have to be cognizant and do a lot of teaching with mom. This is why we really want them to breastfeed. The breast milk is so much better for them, and they don't need all of that, all of formula and stuff. It's not good for them. The intestines actually are basically they're compared, I saw something that said compared to the adult, they had given but they are longer than the adult intestines. So that means that it takes a little longer for the first stool sometimes to come about. But that also means that they could have congenital stuff go on with the intestines that you don't realize until after the infant's been delivered, even a few days or even 5 days, you can get into problems with having to do with the intestines. The digestive enzymes, basically it's pancreatic amylase that's needed for the complex carbohydrates. It really isn't in full swing. I know that's a weird way to say that. For the first 4 to 6 months. So what does that mean? If the ability to digest complex carbohydrates is deficient for 4 to 6 months after birth, what is that telling you?
They need to remain bottle fed or breastfed for the first 4 to 6 months because they can't break down food.
Yes, yeah. So these moms that think, or these grandmas, they're kind of the ones, it used to be when I had my kids, oh, put a little cereal in their formula. Let me give them a bottle of formula and I'll put a little cereal in it. Well, they don't digest that. They don't have the ability to digest that, okay? So it's really one of those things that it's extremely important to speak to the mom. Again, a lot of MIU and OB and NICU nursing is education to these new parents or to whoever is taking care of this, going to take care of this infant. Are there people asking me stuff? Let's see. Does that mean that they need to eat more frequently? Yes, Isaac, you're right. Yes. Kelly, sorry, I'm just looking back at the chat. Kelly, it's okay. Don't get too hung up on the embryonic period. One says 3 to 8, one says 3 to 7. I'm not asking that kind of stuff. Okay. I want you to transition all of that to what's going on with this baby at delivery in those few days or few weeks after. So Isaac had asked, let's see, also what would happen if you did put cereal in their milk? Well, my kids survived, but all it does is they don't really digest it. And I think that's probably why that wives' tale got started, is because it sat in their stomachs and in their intestines for a while, right? Until the intestines moved it on out, because and so the infant stayed like full, so they wouldn't cry as much, and that was why it started. Hugo. So stools progress. I think, who was I with the other day that we changed the first meconium? I think it was Nick.
No, it was me, Raul.
Raul?
Yeah.
That baby, that was sticky, gum like, I can't even explain it, right?
Yeah, it looked like tar, you know?
Yeah, exactly. And actually that was kind of watery, really. You can have some that's so thick it is like tar, and trying to get it off the baby and get them cleaned up it can be difficult. And that is why that first stool, if that's done in utero and that baby is taking that into their, basically they're swallowing it, it's going into their lungs. You can see if they've sat in that a while, why these kids get in so much trouble, right? Oops. Let's see. So hepatic system, the liver, I've said a couple of times, liver is immature. But that being said, it's important to keep the blood glucose levels within normal range. It needs to help break down all of these baby red blood cells that are breaking down, and that bilirubin coming off those red blood cells that liver has to get rid of that. And usually it can't keep up with it. So it starts putting it off into the skin. Very normal to have maybe down to the chest to have some mild jaundice in that first few days. It should progressively get better. But if you have an infant that delivers and they almost look jaundice from the very beginning, and within hours after birth, they look jaundiced, that is a child that's probably going to need a blood transfusion. So blood glucose, another huge issue. So I already said temperature is huge, glucose is huge, right? So because we already talked about, from the very beginning, they need to use a lot of glucose and to get their metabolism going, for breathing, for they need the oxygen to help with break down the brown fat, and everything has to be working. So they can get into trouble with having hypoglycemia. These infants here are at their greatest risk. So a preterm or late term infant, a small for gestational age. So just offhand, what do you think it means when I say small for gestational age?
Underweight or smaller in size than they should be for where they are in gestation. Or
right. And they're not necessarily preterm or late preterm babies. They're just, this could be a term baby that's SGA. Sometimes it can be SGA for it's genetics. Mom has small babies. You know, people will get all stressed out. Oh, this is a 4.5, 5 pound baby, but you look and she and her other 3 babies were all the same. And the baby's eating and keeping its temp and everything's fine. But it could be small for other reasons, and we'll kind of touch on that. Large for gestational age babies, again, like you said, they're just big for you could have a 38-weeker who's 9 pounds. So now, whether that 38-weeker LGA baby is that way because of genetics, or is he that way because mom was an uncontrolled diabetic, and now you actually have a baby that you're really concerned about hypoglycemia on. And we already talked about cold stress and being exposed to other stressors. So signs and symptoms of blood sugar is low. The reason why these things are important is you can see that some of the very first signs is the baby might be breathing a little fast. I don't think I've seen any babies lately that are jittery, but they're just every time you look at them, they kind of do this little twitching. That's jitteriness. Or maybe they have this high-pitched cry. But as you look at all of these, you have to understand when the baby is exhibiting these, for whatever level the sugar is low, ultimately you could have a baby who ends up seizing, and you could have a baby that ends up with brain damage. So hyperbilirubinemia. So again, physiologic jaundice, just what I said, it's just hemolysis of the red blood cells and the liver being immature, that first 24 hours of life. you might see a little bit of physiologic jaundice. It should go away. But here, this pathologic jaundice is like within 24 hours, you have to get phototherapy on them. And I've had babies where we've had to go ahead and do an exchange transfusion, that it was that bad. Breast milk, jaundice, I always have a hard time really talking too much about this, but it is a thing. Every once in a while, you'll get a mom that actually she's breastfeeding, and they say it's lack of sufficient intake here, but sometimes it's actually whatever is with her breast milk is transferring to the baby and causing this high bilirubin. And you have to have her stop breastfeeding. But we try, like really try hard not to do that. If you have a baby go into the NICU for whatever reason, and mom truly wanted to breastfeed, unfortunately, a lot of times, depending on the doctor, they'll really push bottle feeds for that baby. And then true breast milk or late onset jaundice. This is something that occurs 3 to 5 days out. It can last 3 weeks to 3 months. Am I going too fast? Are you guys still good?
No, it's perfect.
Okay. Oh, Kelly, you said they stay asleep longer because they don't wake up hungry. Could, yeah. I think more though that you'll find that those babies end up going to the doctor's office and they are actually overweight because they're just getting these kind of almost an empty calorie that the body can't digest. So this is just a slide talking about where sources of bilirubin, the bilirubin, or the why this baby's getting hyper jaundice, and a name just went out. But so bruising, cephalhematoma, we already talked about destruction of the RBCs, and then for some reason the RBCs are breaking down for a pathologic reason. Okay, so just take a look at this. This is not something I would give a test question on this part down here. That gets into other issues, maybe if we had a sick baby, but maybe knowing how a baby, like the bruising, cephalhematoma, the normal destruction of the RBCs in, these 4 things for sources of bilirubin. Excess production, so risk factors. Let's see, can I think of a baby, excess production of erythrocytes? I'm trying to think, I know we've had, but I think that's just can be a normal thing for the baby. Short red blood cell life, lack of albumin binding sites, liver immaturity, blood incompatibility, and preterm and late preterm infants. So blood incompatibility, what are you thinking about when I say that?
The mom's and the baby's blood is not the same, so it would be like the RH, how Maricruz said.
Yes, the RH, right. Isaac said ROGAM, Maricruz, yeah, the RH incompatibility. These are some other risk factors, and we talked about the intestinal flora. It's lacking. Delayed feeding, the cephalhematoma, fatty acids from cold stress, or if the baby's had some sort of asphyxia. Family background. Sometimes you'll have, if a mom will even maybe say to you, oh, does he look yellow? And you ask them, say, oh, why did you ask that? Did your other baby have jaundice? Did you end up having to put him under lights. Myra, were you the one with me? That the baby was, the mom said that her baby was had to be under lights? Is
No,
Myra here?
I don't remember.
No, it was,
No.
okay. And then other factors might be the mom's diabetic. Maybe she's on a particular drug. So then we can move into the urinary system. Again, kidney function is complete by 34 to 36 weeks, but it takes a little bit for them to, a few days of life for them to be up into adult kidney status. Now, that being said, I shouldn't say that. It's going to be, their kidney status is going to be a little less for a little, oh, sorry. I want to say it's like their kidneys are fully formed, but they're not as able to filter and absorb, they don't have that. I know what I wanted to say. They don't have the distinction between actually keeping the sodium if their bodies need that sodium, or keeping, holding back potassium. They just are all or none kind of thing. So they're just whatever fluid you put in, you have to be careful because the baby has trouble distinguishing between sodium and the different electrolytes. First void should occur within 24 hours. Definitely. We used to have patients, moms going home at like 12 hours after the baby was born, and they would not have had a void yet. So you'd have to tell mom, make sure if you don't see a wet diaper by tonight or by tomorrow morning to give us a call. Very quickly, we stopped sending moms home that soon, because that's a lot to put on a mom to remember. Hey, my baby really hasn't peed since delivery. And this is another thing to remember, that normal diuresis in the babies are born, and this is fine for a term infant, but if you have a little tiny baby, it will have a normal diuresis, and they will lose 5 to 10% of their weight. So that is going to be a normal weight loss. If you have a baby that is getting into 12%, 15% from birth weight, that is a baby that's going to get into some problems. So here's a good thing. So the first 3 to 5 days, this is what you want the baby to be taken. Always pay attention to the kilogram. So 60 to 100 mLs per kilogram per day. And then at least the baby should be voiding 1 or 2 times a day. And then after the first 3 to 5 days, you should be seeing at least 6 voids a day. And I tell the parents with breastfeeding babies, they can have a stool every time you breastfeed them. Okay. The immune system, neonates are less effective at fighting off infection than even the older child or adult. Keeping this in mind, those babies that are being breastfed are going to have at least some protection that's being transferred from mom. The IgG crosses the placenta. This is the only one, I believe this is, I believe the IgG is the only one that crosses the placenta in utero and provides the newborn with the passive temporary immunity. Okay. The IgM helps against the gram-negative bacteria, and the IgA does not cross the placenta and must be produced by the infant. every once in a while, you'll see an infant getting an IgA immune globulin due to, well, actually, I've seen it given for babies that have the high bilirubin, extremely high bilirubin. Babies don't typically, newborn babies don't typically run a fever. I mean, that being said, I have never seen a baby run a fever that wasn't maybe that we did to them, like we left them under the warmer too long, so now they're hot. Typically, they will get cold if they are getting sick, especially in those first few days. And that's why if you have a young, a newborn that you got in report that his temperature was 35.8 and they've stuck him back under the warmer, or they wrapped him up and they put him next to mom. If you get in a report that they've been doing this with this baby, a full assessment, like check the sugars, check the temperature, put the baby may need to go to the NICU, and it may need lab work because it could be septic. And babies, when they are septic, they can get sick and die very quickly. Okay, I never really understood that until I was in the NICU. But so the psychosocial adaptation, now this we're talking about, and this we'll talk more about this when we do our case study. That being said, okay, we have enough time. The first period of reactivity lasts up to 30 minutes. This is when the baby's newly delivered, and those of you who've seen these newborns right after delivery, they'll be kind of laying there with their eyes open or crying, and you put them next to mom, and it's a fantastic time period for them to go to breast, okay? Moms usually love this time. They sit there looking at the baby, and the baby seems to be looking at them. The next period of reactivity is basically period of sleep. And this can last about 60 to 100 minutes. And they will fall into a deep sleep. So that is why it's extremely important right after the baby is delivered to put the baby next to mom. Even if he's not interested in breastfeeding, put him next to mom. At least you may the baby's going to get that time of bonding. That's extremely important, because if you wait till they're asleep, they're in a deep sleep that you're not going to get the baby to breastfeed. You won't be able to do really anything productive with this infant. So that's why we say, let mom have the baby in that first 30 to 60 minutes. And then after that, we can give the medications. We can do whatever we need to do with them. And then the second period of reactivity is about 10 minutes to several hours. And this is just a time where the baby's awake, and hopefully it goes to the breast, and they become more interested in feeding. Let's see, kind of went through this already. So deep behavioral states, again, these are the different states they'll go through. And so now we're going to go into assessment. Do you want to take a 10-minute break?
Sure.
Okay. 10 or 5? I'll do 10. Hi, Celeste. Just a sec, Celeste. Hello, sorry about that. I had my watch, but not my phone.
You're not muted.
Yeah, I have a few minutes. I'm just on a little break here from Zoom.
Don't forget you're not muted, Miss Thorpe.
I'll send her a text.
She could have us muted.
That sounded like she moved away far enough to where we won't hear.
Okay. I send her a text just to make sure. Tell Celeste hi for us.
What's that?
I told her to tell Celeste hi for us.
If anybody know who Celeste is, you can tell her to take more than 10 minutes. That way we have longer.
Hugo's just trying to not have to do this case study.
It's Friday. I'm trying to not have to do anything.
Cheers to that.
Does anybody by any chance know if the community planning document, if we all need to upload it or if there's just one person from our group that needs to upload it? I noticed that she like added an assignment for that today.
Chirp, chirp.
Okay, I'll message Solinger and ask, then we can all know.
Just grab that one. How many do I have right now? Okay, we have ours, that's the bigger. Yeah, yeah.
Okay, for anybody still listening, it looks like it's a group assignment, so only one person from each group has to turn it in the community planning document.
Thank you, Emily.
When she comes back, somebody tell her to restart her computer. Let's see if we can get her to mess around.
Okay, everybody back?
Yep.
Yes.
Okay, and you still can see my screen,
Yes.
and it looks like it's still recording. Okay, I think we're good. All right, so everybody already had to sign off on their assessment. See, this is going to be a little kind of behind a little bit here, but so starting with the assessment, after we just kind of went through those different areas of the infant that what you need to pay attention to. So starting with they come out, they should immediately give you a cry, right? Or at least some sort of respiratory effort. So paying attention to what color they are, your as you're drying them, are they pinking up? You know, the acrocyanotic is one thing, cyanosis is another. Cyanosis, you can tell by looking at their lips and their tongue, their central part of their body, that's when an infant is cyanotic. That's blue, okay? If and then thermal regulation, you're taking an axillary temp. Very, very, very rare that you would take a rectal temp, okay? And with preemies, you really try to avoid this because you could end up causing harm, and we don't want to cause harm. That's not our job. So here's acrocyanosis. This can be normal. I think it's like 24 to 48 hours is a pretty normal thing. If you notice that the baby now is a 2-day-old, or maybe she had her C-section, you know, almost 3 days ago, and the baby's still acrocyanotic, and maybe you even notice it coming up on the leg, that is more of an issue, and it very well could be a cardiac issue. So paying attention to when that goes away. Taking their temperature under their arm. These are normal vital signs. I think you all, any questions on this? Because I think now that you've been doing your assessments and you've all had to sign off, I think you all probably haven't had much of a chance to do blood pressures, but this is norms. So starting from the head, we're looking for molding, what the fontanelles being soft and open. Does the baby have some caput? Does he actually have a cephalhematoma? Facial symmetry. So here, there's just some really, you know, pretty good pictures here of palpating the fontanelle. This is a baby with some caput, and so it's back here. And caput basically is edema, okay? It's usually just kind of it's not blood. It could be a little bit, I guess, but it's just edema. It's from the baby's head having to go through the vaginal canal. You would obviously not have this on a C-section baby unless the doctor decided to put a vacuum extract on the baby to pull the baby out, which we did have a doctor doing that a lot at SVMH. So, so that this is normal, okay? Now, that being said, how long do you tell a mom that when does this go away? Do you know?
But after a few days.
Yeah, after a few days, it should, you know, we always, we tease, and I don't know, I stopped kind of doing that, but that they would have a little cone head, but that would go away after a few days. Now, if it's a cephalhematoma, it's going to take a little longer to go away. And this is usually something that develops. You might notice sometimes what happens is the baby's got caput and a cephalhematoma that's forming. You don't really notice it because you see the caput. But then after about 24 hours or so, you notice, ooh, the baby actually has what I think is a cephalhematoma. And if you see, basically it's being stopped by the suture line, okay? So the blood is in this area, okay? And it's usually caused by, it can be caused by a vacuum extraction. You guys know what I'm saying when I say vacuum extraction, right?
Yeah.
Okay. So it can, this here can take 2 to 3 weeks to go away. And you can sometimes have some babies that have a pretty large cephalhematoma. Now, what are some other risk factors if a baby has a cephalhematoma? What are you thinking? Sorry. What do you?
Bruising and leading to jaundice.
Bleeding,
Bruising and what?
increased intracranial pressure, possibly.
Jaundice.
I did, the dog started barking. So did you say increased bilirubin? So this would be a baby that you would be concerned that, let's see, that you would just be concerned for a high bilirubin, okay? Especially if they have a large cephalhematoma. You could have babies that have them on both sides too, for whatever reason. Oops. Oh, wrong way. So assessing for anomalies, you're going to go from, obviously now we're at the neck and the clavicles, you're going to go down to the cord extremities and look at the spinal column. You have the assessment of the hips. What is this called again?
It's like the O, it starts with an O and a B.
Yeah.
Barlow.
Barlow and Ortolani. Yep. And basically you're looking at that both legs should abduct equally, and you shouldn't hear a click. Has anyone done this with a real baby yet?
Yes.
Yeah. Okay. And then the next thing you do while assessing hips is you're going to turn them over, and the creases should be equal on both sides, right? If you have a baby that has maybe a hip dysplasia going on, your creases would be off because one leg or the other like if this hip was having problems, it might be, this whole leg might be up. Okay, it would be not symmetrical. Measurements, you're going to be weighing the baby, taking the length, head and chest, checking the reflexes, eyes, ears, just going through making sure everything looks normal. Does this baby look a little yellow to you? He looks a little yellow to me from the face down to about here. And then this here, this probe, if you have a baby that's going to stay on a warmer for any amount of time, this is called a servo probe. And what it does, it goes to the baby's abdomen just like this. And this cord goes up to the giraffe or the whatever device they're on for a warmer. You set the warmer, and the baby's temperature puts out the heat basically. So if it's sensing, oh, this baby is cold, it goes up to the machine and it puts out more heat. So these are extremely important to have on an infant if you are walking in and out and you aren't really and you have that warmer on, or you may have the warmer off. It'll give you an indication. Okay, so these are the different reflexes, and you all have done lots with this, right? So you have the Morrow, the Babinski, the Palmer, the rooting, plantar, sucking, the tonic, that's a good picture of the tonic neck reflex and the stepping reflex. And you all have done, any questions on these? Because I feel like you've all done this. You guys are good? Ear location, again, just making sure they're symmetrical or I don't know if symmetrical's basically they should be in line with the eye. Okay, the top of the ear in line with the eye. Here you can see this child, low set ears, probably indicating some sort of syndrome. Sometimes it's something like, there's other things usually you notice with the baby. Alcohol syndrome, fetal alcohol syndrome, Down syndrome. I think trisomy 13 can be another one. And then you're going to assess the hepatic function. And again, we're looking at sugars. So observe for signs of hypoglycemia. If you have a blood sugar of 30, that is too low. You want to keep it 45 or above. I guess if we did have a 30, you'd want to make sure the baby got to the breast and that you would reassess within about a half hour, 45 minutes. And again, signs and symptoms of hypoglycemia. We went through that earlier. When you obtain a blood sugar. So you can see here why it is so important. What I've been teaching students is put your thumb on the infant's foot, basically kind of like this. Can you see that? You're putting your thumb right here. And then this is where you're gonna poke the baby. You can see how many, you have the medial plantar nerve and you have the calcaneal nerves that come down. Early on, before they really were paying much attention to this, preemie babies who were in the NICU for a long time, you could tell as they got older because they would not walk on the back of their foot. Okay, they wouldn't use their heel. So it's extremely important to use the right place that you're doing that. The GI system, you're looking at the shape of their mouth, how's their suck, when did they first feed, are they feeding, what does their abdomen looks like, and have they stooled? Kidney palpation, not usually part of the assessment. Mostly you're just paying attention to has the infant urinated? The only other time you might, and I still don't really palpate the kidney, but you may have gotten in report that there was only a 2-vessel cord, which means that there could possibly be, the infant could possibly have only one kidney. That's a possibility. So if they know that ahead of time, they may choose to go ahead and do a renal ultrasound on the infant. For the female, the labia majora should be larger than the labia minora, and it should cover the clitoris and the labia minora. You might have a small amount of vaginal discharge. Every once in a while, you even have a little bit of blood. That's like a pseudo menses on females, and it's really has more to do with mom's hormones, and it's not anything bad, and you just tell mom that's a normal thing. The male, term male, the scrotum should be more pendulous, and not tight. Like you could have a scrotum that looks term, but it's actually looks like what we call a hydrocele, where there's actually fluid in there and it's tight. So when you go to try to see if the testes are down, you can't because it's that tight. That is just something you want. The one thing that's concerning about something like that is you want to make sure there's not anything going on with the testes. Let's see. Okay. Skin. What is, oh, well, it shows you what it is. I wish that would go in here. So this is lanugo, okay? Most of the time as the babies are term and they've maybe a 40-weeker, 40 and 5, you may not have any of this, or you may have splotches, like, but a lot of times this maybe is a, I don't know, this could be a 38-weeker. Milia, the little white, there's sebaceous glands, and you tell the parents, please don't pop them because that's normal, they'll go away. They're only in there in the first couple, maybe week or two. Now, this is also interesting. This is erythemy. Oh my God, I can't talk. Erythema toxicum. And it looks ominous, doesn't it? It looks like little flea bites, is what I always say. What do you, have you seen that?
No.
No. So it can be concerning, but they actually do look like little flea bites. It can be a normal thing with infants. It can start showing up around the first 24 hours. And it actually, in the book, it says it can last up to 3 months. But again, it's not ominous. I was trying to find the other name for this, you guys. The other name only one I could find was a slate gray nevi. And I would say it's this and this. And they are bluish gray marks that resemble bruises on usually on the sacrum, buttocks. They can be on the arms and shoulders. They're most frequently in dark skin newborns, and they usually disappear within a few years after, when they're 2 or 3 years old. They are, I think that's about all to say about those, but I actually see a lot of infants with these. Has anybody seen one?
Yeah.
Yeah.
Okay. This they're talking about, so this is nevus simplex, and I want to say they're talking about in here. Otherwise, I'm not. It's a stork bite. Where is it? Oh no, sorry, it's right there. They call them a stork bite or salmon patch. Honestly, I usually hear stork bite. And their birthmarks, the color blanches when they pressed, and it's more prominent like when the baby starts crying. And they usually will disappear at about 2 years. Sometimes babies will have them here or on the back of the neck. Usually they'll go away. This is more of a permanent. This is permanent, and it's flat, reddish purple mark, and it may vary in size and where they're located. They do not usually go away. And sometimes, you see there's different variations of this. This will go away. There's some that get worse. up until about 6 months. And then they reside, start going away. I don't know if they have one, but there are some that don't go away, that actually have a blood vessels or small blood vessels and everything through them. And they actually continue to grow. And so it's something that the parents have to deal with. I remember we had a social worker whose infant had this, and I think it was a few years they kept going back up, and I don't know how it actually all resolved itself, but I know it got really, really large. So gestational age assessment. I think the best way is to show you, this is what's called a Ballard score. And you can see that the areas are set up in neuromuscular and physical. Typically what you guys are doing in your assessment, some of it is, well, no, I guess not. So for the neuromuscular, you start off by just looking at the posture. And we'll go through these: square window, arm recoil, popliteal angle, scarf sign, and heel to ear. And then down in the physical maturity, you're looking at these items. What happens is you give them points for each thing. So if you were the nurse doing this, we used to have the actual papers. Now you have to do it on the computer. You would go along and click and write, check mark what you thought was the infant. Then you would take those two scores, add them together, and you would go over here with that score and go across, and that's what would give you your Ballard score, or your it's gestational age by using the Ballard score. That being said, when we first do them, you document, this is what we got for the first score, when we did it, what time, how old they were at the time of the exam, and who did it. And then they'll do, usually, maybe at 12 hours of age, you might repeat it. Any questions on that? I see chat room going. Hyperpigmentation. Yeah, that was, I couldn't find that written like that anywhere, but that's kind of what I was thinking, Christine. Hyperpigmentation for the Mongolian, or that other it was for this one, hyperpigmentation. I don't know that it gives you a clear enough picture, but because you could say anything is hyperpigmentation, but so posture of newborns. What do you think the age of this baby is? Do you think these gestational age-wise that these two are the same?
No.
No.
B looks younger.
B looks younger, yes. And look at the difference in subcu tissue on this guy compared to this little one. So you can see this kiddo is going to get into problems with hypoglycemia, temperature, issues like that if you're not careful. This is a square window. So you can see on a term baby, this is what you would get. And you see that angle right there is what you're paying attention to. Again, if you went back to this, here is your square window. So the more term you are, the less of a angle you have. All right, and this is a little preemie, so you have a wider one. Arm recoil, or Moro reflex is another name. So basically she puts the arms up, or he puts the arms up, puts the arms down, you kind of hold it, and then they should pop it right back. And usually they'll spread their hands out too. So again, going back up here, in the arm recoil on a baby that was term, they should put them right back up. Or if the baby was a little more preemie, they may just kind of put them out to the side and down. Do you see where I'm going with this for the Ballard assessment? And then here, the popliteal angle. This is what you're doing. You're taking the knee, you have the knee to the chest, you're bringing the foot up, and you're looking at this angle. You can see here, this little guy, extremely more preemie. And when she puts her, how much of an angle you have, right? Scarf sign. Heel to ear. This is a little different because you're not keeping the knee at the chest. You're just taking the leg. You have to maybe sometimes put your hand on the other side so that the whole baby doesn't come up. But you can see how the tone in this baby, this is a term baby, this is a pretermer. So physical characteristics, that bottom half of that graph, you're looking at the skin, lanugo, plantar surface, the creases on the bottom of the feet, breast buds, the eyes, the ears, and the genitals. So here's a baby that's term. Here's a baby that's not. She's measuring here. She's measuring the actual breast bud. So this here. And you can put your finger on them and you can feel the tissue under there. On little preemies, there's nothing. But as they're more term, that will have more breast tissue there. The ear maturation, this you're taking the top of the ear, bending it back, it pops back, normal. This little guy, you probably would do that and it may just kind of slowly go back. This is a term, more of a term female. This is a premature female. Male genital, here's on the scrotum, you have the rugae. The other thing you're when you're looking at these babies for assessment is make sure that the urethra is in the center of the penis. And then here, his little scrotum sac is not fully formed. I mean, it's fully formed. He needs to grow. So, but this is normal for him. The testes may or may not be down. Usually they're still a little bit undescended. So now we're going to go into just different variations of babies. When we talk about, and we talked a little earlier about an LGA infant, their birth weight is greater than 90 percentile of their gestational age, and you graph it between seeing what their Ballard assessment comes out, and then you graph their weight. You get a really good idea of how old this baby is and where their weight is to their gestational age. They might be this way, like I said, ethnic or genetic factors. Males can be LGAs more than females because they have more of a lean body mass. And it could be related to mom's glucose levels. And so the baby has gotten, basically, the baby's pancreas has had to put out so much insulin. What do we also know what that does to a baby? What is that other? What do we know? Another name really for the insulin that's getting. So it really is a growth factor, right? It really causes the baby all of this extra sugar and the insulin getting put out by the pancreas and the growth hormone, all of this stuff makes this baby like this. This is a true, what you would think is an LGA baby. He looks kind of borderline. So here we have infant with, I'm noticing let me know if I'm missing stuff. Yeah, good, Isaac. So infant of a diabetic mom, again, usually an LGA baby. This guy could very well be or girl, could very well be a 35 weeker, right? But it's just a big baby now. So with these kiddos, they can end up really sick. So the blood sugar can just bottom out on you. I've had them at 10. They can reach, it takes a few days sometimes for these babies to get their sugars actually within a normal range. So what we have to do with them is bring them into the NICU, that he probably would have a line going, and we would give them D10 to help until they're, and then you just kind of wait till the baby's pancreas and everything starts normalizing, basically. But these kiddos could get into respiratory distress. They polycythemia, which, what does that do? They end up having higher bilirubin levels. So they end up under the lights, and they can end up with renal vein thrombosis and this metabolic type syndrome that you're watching them for. So basically really low sugars, and they can get into really low calcium blood levels. Yeah. Are you guys good? Yeah. So I hear somebody's stuff, but so what we have to understand when we have these moms that they could be type 1 diabetics who are getting pregnant, or they could be type 2 already and get pregnant, or they could become diabetic while they're during their pregnancy. So first of all, they need to understand the risks of being diabetic during their pregnancy. A lot of times the ones I've seen, the moms who have uncontrolled sugars and who aren't staying on their diets, and mom's sugar goes from way high, and then she'll come into the hospital, we get it all stabilized, and then she goes home and goes way high. What that is doing to the baby during this whole time that they're in utero. So you can end up with babies with heart problems, cardiac problems. They could end up with GI tract problems. It affects their kidneys. You could end up with an increased risk of fetal death. And I have seen that, where the mom sugars were so extreme back and forth that eventually the baby it was a fetal death. And then here you have SGA infant versus an IUGR. So SGA infants they're just tiny babies. So everything looks normal, how they should look, but they're just smaller compared to other babies. Depending on how little they are, they could get into problems because of what we talked about with sugars, and you kind of wonder if this wasn't a genetic kind of thing, what was going on in utero, why the baby ended up being small. Now, intrauterine growth restricted infants are infants that are chronically stressed in utero, and they have spent their whole time in utero just utilizing all the glucose that's coming across, just basically for survival. These little ones come out and they struggle. They can be your ones that go right to the NICU because they have nothing to work with as far as glycogen stores. So again, factors that affect our glucose stability are going to be the sick infants and preterm or SGA babies. Here's a quick question. A newborn is placed under a radiant warmer. The nurse knows that the thermal regulation presents a problem for newborns because, what do you guys think? What do you think?
C.
Yes, C. Good. Any questions? Yep, good. Look at that. You guys are able to go on there. Okay, let's see here. Let me go back out and come in here. And go to, I don't think I opened that one screen for you guys, huh? Nope. So I think I did open it. This in-class assignment. Do you see it? Just go to here and it's the Google Doc.
It says we need access.
Oh, I did. I thought I did. Let's see. Okay, I thought I did. Let me see. How do I do that now? I thought I already had that.
So go into your Google Doc, and then I
Uh-huh.
can walk you through. I can walk you through how to do it.
Okay, here's this.
Okay, so you're gonna go into the upper right-hand corner and click on where it says share,
I thought I did this, but maybe I didn't. Okay.
and then down hit change because your Hartnell group is different than our Hartnell group. So click Hartnell College again and change it
Oh,
to anyone with the link.
that's what I didn't do right. Okay.
Yeah, it's confusing.
Okay. So can you see it now? Maybe refresh your page.
Yeah, now I can see
Yeah,
it.
we can see it.
Great. Okay. So this is we're going to go ahead and do this. This is the one that you're going to turn in for 5 points. So we'll just do it now like we did last time. Does that sound good?
Mrs. Thorpe, are we supposed to be able to type stuff in here? Because I can't, I think we're only on the viewing option.
Oh, so how do you do that? How do you
Click
change-
on share again. Yeah, click that
Uh-huh.
button.
I think if you click open with Google Docs, then it will take you to Google Docs and you can write on it.
So you're going to want to click where it says get link right there. You're going to want to click change. And then where it says viewer on the right, you want to change that to editor.
Geez, there's so many little things here. Okay. How's that?
People may have to refresh it also.
Yeah, it works now.
Nice. Okay. So YC was in labor for 12 hours, gave birth vaginally to baby H, and it's her first baby. The nurse will complete the physical assessment and observe for any physiologic changes in the newborn's transition from intrauterine to extrauterine life. So we talked about this. Name 3 phases that occur during the newborn transition period and state approximately a time frame for each. To give you a hint, it is in the PowerPoint. Are you guys here till 1? Or
12:50, 4 minutes.
Oh, nope. Who's doing this one? So what they're asking is, go back to those sleep phases. So the first period of reactivity is the one right after birth, the 30 minutes that I said, that's a great time to put the baby to breast and, okay. So it wouldn't be this. Okay.
And Miss Thorpe, are we submitting this all separately?
No,
Okay, thank you.
no. Let's see, because I think I have everybody still here, so I'm going to just give points for everyone. So what do you got? Yeah. And then anyone know what the second phase is?
It's the 60 minutes, 100-minute sleep. The sleep is decreased activity and deep sleep.
Deep sleep, yes, yeah. And then the last, the last one is the second period of reactivity. So this put. And then this is. And then we're just going to say period of prolonged sleep. Okay, and just know those time periods in there. Okay. So identify the care specific to the first part of reactivity. They are wide awake. You want to give the baby skin to skin. Good, Brittany. The sleep phase in second might occur in the nursery while the newborn. Identify 8 assessments. You guys can even just. What do you think you would do while they're in the nursery? Yep. Observe them. You're going to monitor their vital signs. You might need to take a glucose level if they're LGA or SGA, or if they're preemie, or if you know mom is a diabetic. You're going to go ahead and give the vitamin K, hepatitis, and the eye ointment. And do your physical assessment, document. Now they don't do the bath right off. Okay, you're just going to wipe them. I don't know how Memorial's doing it, but Natividad, they don't do the bath. I think it's for 24 hours, quite honestly. Document if you have any kind of stool or void at that point. Okay. Good. Who's my, you're doing the vitamin K. So actually, yes, you have that right. Okay. The order is to give 0.5 milligrams. Oh, they're doing this. Okay. The order is to give 0.5 milligrams. So you really need to, this is where milligrams per kilogram for dosages and everything you want to pay attention to. Okay. Good. And why is erythromycin given? Good. Who put that? Oh, no, that's not right. Sorry. Erythromycin is actually given for gonorrhea. So,
What I'm reading is the most common cause of ophthalmia neonatorum is chlamydia, and a less common but more serious cause of ON. And the reason for mandatory erythromycin eye ointment is gonorrhea.
right, so the question's asking, remember guys, is why are we giving the erythromycin? It might be that chlamydia is the more common, but we don't give erythromycin for chlamydia. We're giving it for gonorrhea.
Well, we give it to avoid the ophthalmia neonatorum, which is another word for pink eye. And both of those cause pink eye.
It does mention both of those
Does
in ATI.
erythromycin do anything to chlamydia? You know what I'm saying? Like, what is the sensitivity to chlamydia to erythromycin? I know gonorrhea is sensitive to erythromycin. So given those choices, this is one of those questions that can sneak up on you. Knowing that erythromycin actually is used to treat gonorrhea is something you would need to know in that.
It's worded a little funny in ATI. It makes it sound like it's for both.
Really? Then I wouldn't put this question there. I wouldn't give you this question then, if it's that vague. But my understanding is it wouldn't be used for chlamydia. It would be used for gonorrhea. And then once transitional care and documentation are completed, the infant might be transferred to the normal newborn. Let's see, keeping the baby clean, encourage the development. Okay, so clean is good. Airway is another thing, right? Taking vital signs, making sure the baby is warm. Is the baby breastfeeding? How is the baby breastfeeding? Paying attention to if they want a circumcision done, starting that process. PKU, basically though, this is something that the lab comes up and does. And just education, keeping the parents educated on plan for discharge, what's normal, what's not. Actually, the lab performs a Kuhn test on the baby H. What is the purpose of the Kuhn test? Actually, it's this. Oops. To test for damage to the RBCs from the maternal antibodies. Remember the Kuhn's test, or you may not know this. The Kuhn's test is for Rh moms, for Rh negative moms. So we test the baby's blood on the cord blood. We get the baby's blood type and we do this process. You want to see, I mean, sometimes if the Kuhn's comes back 1+, or they'll give you a plus factor. Those are indications the baby is most likely going to get very high, have a very high bilirubin. It's going to get jaundice. You're going to need to do more with the baby. True or false? The PKU test can be done anytime before the infant is discharged. You are right, Hugo. I think I saw you put, or Alfredo said no. They need to basically, you really want to have this done. So what you want to have done is that they've had that breast milk and had some sort of feeding going on. And usually that's in the first 24 hours. And that's when they would draw the PKU. Now, there are times where our little preemies go out before that 24 hours and they're not getting feeding. So in those cases, because this is a state mandated thing, we could decide, okay, are we going to do it before they go? But they would have to repeat it when the baby got up to wherever they were going. The other thing you have to make sure is before you would give blood that you drew a PKU, or at least have that documentation that you didn't do the PKU before blood was given. 6 important points to include in a teaching plan. Wow, you guys are good. Excellent.
Miss Thorpe, I have a question.
Yeah.
The PKU question, I think the answer says that low levels indicate Down syndrome and high levels indicate neural tube defects. But isn't that statement for alpha
Yes.
the protein?
Yes. Where are you seeing that about the
Number 8.
I know, but
The answer that I think.
did someone put that for an answer? Let's see.
Yeah.
It's more that about the
metabolic disorder.
No,
right?
it's not this, you guys. It's not that. Okay. It has to do with the protein, with the ingestion of proteins, and there's all sorts of genetic diseases that they test for. And when you're in the hospital, go find that pamphlet they give to the moms, because it'll list what California tests in that PKU. Different states test for different things. Of course, nothing's all on the same. Thank you for bringing that up. I did not see that. But yes, the alpha fetoprotein is for the neural tube defects. Let's see. Anything else that you have questions on here? I'm trying to see if we. The other thing, let's see. By opened air. Let's see. Proper hand washing, excellent. Okay. And let's see. Pediatrician, the growth. The other thing to talk to him about is immunizations. So you would maybe you could go ahead and help her understand what the immunization schedule is, talk about growth and development. But I usually tell them on that first visit to the doctors, they usually will have the PKU results. They'll talk about the immunization schedule, and they'll weigh the baby, and just to make sure that they're staying, on the growth curve, that they're normal, they're within normal. Let's see. Screen for illness, genetic, established relation. Good, guys. Okay, and then the last one, you are correct. You realize after reviewing safety, you use a teach back technique to assess her understanding. Which statement by YC indicates she needs further instructions? Yes, I can leave him on the table just for a few moments while because he's a newborn. No, those of us who are moms know that that's not true. Those little boogers will flip over just when you think they won't. You can talk, I definitely talk to them about knowing about jaundice and when to call the doctor, keeping the baby, if they are a little jaundiced, in a sunlight, but protected from getting cold. And what was the other thing? Oh, cord care, understanding that the cord could, if the cord gets infected, what it might look like. And actually in this particular thing that I have, the answers are saying to cleanse the cord with soap and water. No, we don't usually tell them to do that. Our instructions are, obviously if they get stool or something up on there, yes, they have to cleanse it. But the more they keep it away from the diaper, keep it dry, keep the area clean. And then if there's anything like, anything that looks like infection is starting, redness, swelling, any kind of drainage, that they need to call the doctor. Baby can get really sick from that. So I think that's it, guys. I kept you over again. I'm sorry. Are you guys good? Okay.
Yeah.
Some people did leave. All right, guys. Any other questions?
We don't have to submit this for points?
Nope. I'll go ahead and give everybody points.
Perfect.
But are you guys able to go back to this and look at this?
Yes.
Yeah.
Okay. All right. That was the only thing. No, because you guys all, everything I was seeing here. I mean, I didn't go through each and every sentence here, guys, but it looks like what you've been writing is good. All right. Oh, the other thing you might want to talk to them about on before discharge is car seat safety. Okay. All right, guys, I'm going to stop recording.
Thank you, Mrs. Thorpe.
You're welcome. Thank you. And
Thank
I'll
you.
post this, pardon me? I'll post this to the modules when it gets done. You know, it takes probably about an hour or so to do that.